The four cardinal features are tremor, usually an asymmetric tremor, so one side's worse than the other, and a tremor that is predominantly present with rest, meaning like when the hand is down, and less so when the hand is out or moving. Rigidity, which is increased resistance to passive range of motion. So when you move a limb at a joint and the person is relaxed, there should be no resistance, and in rigidity there is. Usually manifests to the patient as stiffness or shoulder pain or something like that. Bradykinesia, which is slow movement, and then loss of balance or loss of postural reflex. Your postural reflex is what allows you to stand. So people are inherently unsteady, and we consistently shift our weight to remain upright. That's our postural reflex, and we do it without thinking. In Parkinson's disease, that's impaired, so that when your center of gravity gets off, instead of making a simple shift to catch yourself, it may be several steps, or it may be nothing, and you just fall. So those are the four cardinal features. Patients who have two of the four are said to have Parkinsonism, or the symptoms of Parkinson's disease, and roughly 90% of people with Parkinsonism have Parkinson's disease. There are some mimickers of Parkinson's disease that are part of Parkinson's disease 102, a later course, but 90%. The other very common feature of Parkinson's disease, and many people would say it's a requirement, is a clinical response to levodopa. In other words, that levodopa would make you better. So those are the four cardinal features, with maybe a fifth one as far as response to medication. As I said before, the diagnosis of Parkinson's disease is a clinical one, so you would have the symptoms and history consistent with Parkinson's disease, and then a response to medication. Recently, there has been FDA-approved a diagnostic test that helps in some cases. It's called a DAT scan, D-A-T. It is a radionucleotide scan that images the dopamine transporter. So for this test, you would get an intravenous infusion of a radioactive tracer that would stick to the dopamine transporter in the brain, and then you would have an image with the same kind of scanner that you would for a bone scan or a thyroid scan or whatever. It gives this blurry picture of the brain that you see, and those two reddish yellow dots are the striatum. The image on your right is the image of someone with a loss of dopamine in the striatum that is commonly seen with Parkinson's disease. The image on your left is normal. The advantage of this scan is it does image the dopamine system. The disadvantage of this scan is there are other diseases other than Parkinson's disease where you lose dopamine, so it's not specific for Parkinson's disease, but it is helpful in some cases. But it's the only kind of scanning that we have currently that would be helpful. As far as what really happens in the brain with Parkinson's disease, the motor symptoms of Parkinson's disease, which are the characteristic symptoms for what the disease is named for, the motor symptoms are due to premature loss of cells in an area of the brain called the substantia nigra, which is in the midbrain, that secrete a chemical called dopamine. So the images on your left are of the substantia nigra. If you think of the brain as kind of a ball and then it has that stem on it, the little place where the stem attaches to the ball is the midbrain, and these are slices through it. To give you a scale of reference, those white structures, the midbrain there, roughly 1 3/4 across its widest part. So it's pretty small. The substantia nigra itself is about 3/4 of an inch long, so pretty small. The image on your right is a microscopic view through the substantia nigra, and it shows the characteristic inclusion bodies that are seen in Parkinson's disease. An inclusion body in a cell is an abnormal aggregation of protein that stains. And so it is there. And there is debate as to whether Lewy bodies are harmful, whether they're actually part of the disease themselves, or they are your brain's kind of a natural ability kind of fighting the disease. So Lewy bodies are present. Whether they're good or bad, uncertain. The Lewy bodies contain an abnormally folded protein called alpha-synuclein. And we make alpha-synuclein normally all the time. It can get abnormally folded, and there is some evidence that abnormally folded alpha-synuclein can travel from cell to cell. In other words, that you could have a Lewy body in a cell that contains abnormally folded alpha-synuclein, and when that cell dies, the alpha-synuclein that's in that cell can move to another cell. And there is current theory that migration of abnormally folded alpha-synuclein contributes to disease progression. And that is the basis for when you might be reading about new treatments in Parkinson's disease, and they say they have a vaccine for Parkinson's disease, or they're experimenting with infusions of antibodies for Parkinson's disease. It's not because there's any thought that Parkinson's disease in any way is an infectious disease or a communicable disease or anything like that you would think of as a vaccine. Vaccines or antibodies, whether they are used to fight infectious disease or not, work by attaching themselves to proteins. And so you can make antibodies, or you can make a vaccine against this abnormally folded alpha-synuclein. And that is what has been done. And those agents are currently in clinical trials, or the clinical trials are about to begin, with the idea that maybe those antibodies or the antibody response from the vaccine can pull alpha-synuclein out of the brain and slow progression of Parkinson's disease. So very exciting, hopefully successful. So what causes Parkinson's disease? Why do those proteins abnormally fold in the first place? Well, the answer to that is probably many things. Probably many things. I like to think of it a bit like heart disease. Why do people develop heart disease? Well, maybe heart disease runs in their family. Maybe they eat poorly. Maybe they smoke. Maybe so there are risk factors for heart disease, and it's the accumulation of risk factors and your pre-existing genetics that we think is what determines that you have Parkinson's disease. So there's kind of a saying in medicine in general that genetics loads the gun and the environment pulls the trigger. And what we mean by that is, some people, we all carry some genetic predisposition for various things. And whether or not we develop those things have to do with various environmental stressors or whatever. And we're all kind of used to that. I mean, we all know Uncle Bob, who smoked 3 packs of cigarettes since he was 9 years old, and he's 80 and he looks fine. And Here's another person over here who smoked a lot less, and they got heart disease or emphysema. So we're born with these risk factors. Another question in Parkinson's disease is, when does it start? Now, by definition, we diagnose Parkinson's disease when those motor features start. So, we ask people, when did the tremor start? When did you stop swinging your arm when you walk? Things like that. There's increasing evidence that there are pre-motor features of Parkinson's disease, because this loss of cells, although it's most dramatic in the midbrain, it is not in all patients completely isolated to the midbrain. So decreased dopamine in the brain predisposes people to having depression. So people with 30-year-old people with depression are more likely to develop Parkinson's disease in the future than 30-year-old people without depression. Constipation, loss of cells within the gut occurs in some people with Parkinson's disease. Many people with Parkinson's disease eventually, but with some. So again, 40-year-old people with constipation of unexplained cause are more likely to develop Parkinson's disease than people who don't have constipation. Same with loss of sense of smell. Same with REM behavior disorder. REM behavior disorder is where you act out your dreams. So these are all considered premotor features of Parkinson's disease. Now, realize that all four of these are very common in general. So in no way am I saying anybody who's constipated is eventually going to develop Parkinson's disease, okay? It's increased risk. And it's not, it all depends on how you market this increased risk. A lot of times patients ask about the genetic component of Parkinson's disease, and because they want to know, will my children get Parkinson's disease? I recently turned 45. I more recently turned 58. So at 58 years old, my baseline risk of developing Parkinson's disease at like age 60 is 1%, because I have no family members with Parkinson's disease. Now, if my father had had Parkinson's disease, and he had onset, in his late 50s, early 60s, my risk would be triple, which sounds big, but that's a 3% risk. That means there's a 97% chance I won't develop Parkinson's disease. So for most of you, you could tell your children that the good news is they're more likely to get cancer and heart disease. So Parkinson's disease does not have a very strong genetic component to it. There are also non-motor features of Parkinson's disease. So, we talk about the tremor and the stiffness and the bradykinesia a lot, because that's, again, what the disease was originally named for, and those are prominent. But there are many non-motor features. Some of these are also premotor features. But these symptoms may or may not respond partially to the typical treatments for the motor features, but can be treated separately. So again, depression. Depression occurs before the motor symptoms or during the motor symptoms in up to 80% of patients with Parkinson's disease. And treatment of depression has been shown to greatly improve quality of life in patients with Parkinson's disease. And patients with Parkinson's disease are chemically predisposed to having depression. What do I mean by that? If you don't make enough dopamine, you also don't make enough norepinephrine and epinephrine, which are two chemicals associated with mood. And so if you look at groups of patients who have Parkinson's disease and you look at groups of patients who have rheumatoid arthritis, and both are equal age, equal disability, the rates of depression in Parkinson's disease are much higher. So this idea that, of course, I have depression, I have Parkinson's disease, why wouldn't I be depressed? It's not necessarily that simple. Please don't think of depression as something you should just be able to get over. It's easily treated. It improves quality of life. It's great. Constipation, seen in the vast majority of patients with Parkinson's disease, and is usually symptomatically treatable. Anosmia, which is loss of smell, we unfortunately don't have a treatment for. It leads to decreased appetite and weight loss in some patients, but it is a common non-motor feature. REM behavior disorder, where I said you act out your dreams, talk in your sleep, kick in your sleep, whatever. There are also treatments for REM behavior disorder. We usually treat it if, number one, it's threatening to your sleep partner, or number two, you've fallen out of bed and hurt yourself. So there. Orthostatic hypotension, which is lightheadedness when you stand up and near fainting. Blood pressure generally decreases in patients with Parkinson's disease, and essentially all of the medications used to treat Parkinson's disease lower blood pressure. And so it is common to feel lightheaded when you stand up. It is very important that you remain well hydrated. The lightheadedness gets worse in hot weather. And there are medications to increase blood pressure if that is a problem for you. Finally, cognitive difficulty is also very common with Parkinson's disease. The most common cognitive problem in Parkinson's disease is something that's goes under a lot of names. Bradyphrenia, or slow thought, is the old name for it. Loss of executive function is the fancy name for it. What it generally means is that you have difficulty multitasking, or that you have difficulty with what's called word fluency. You're talking and you can't think of the word, and then a few minutes later you can. Those would be the most common cognitive problems in Parkinson's disease. Parkinson's disease patients are also more likely than people who do not have Parkinson's disease to develop memory difficulty. So classic, and there are medical treatments and non-medical treatments for the cognitive problems in Parkinson's disease. The progression of Parkinson's disease. So it is a progressive illness. It is also a tremendously heterogeneous disease. So if you looked at 100 people with Parkinson's disease who had had the disease for 10 years, they would look completely different. Some would have very few symptoms, some would have a lot more symptoms. So different people progress at different rates, and different people develop different problems. So not everybody is the same. There is some evidence that an individual's rate of progression remains relatively constant. In other words, if people start out more rapidly progressive, they tend to continue to be rapidly progressive, and people who start out slowly progressing tend to stay slowly progressing. But other than that, it's very hard. We do not currently have a biomarker of disease progression. What do I mean by that? What I mean by that is we don't have a way of drawing your blood and telling you that your Parkinson's level is 4.0, like we would for your PSA or something like that. So in research, clinical research of things that might slow progression, it's hard because we have to mark progression by measuring symptoms, and there are medications that mask symptoms, that help symptoms. So generally, trials to look at disease progression are done in very early Parkinson's disease in untreated patients. It requires a lot of patients. Many subjects, not a lot of, because different people progress at different rates. Unfortunately, there is currently no proven therapy that slows progression. However, and this is going to be on the test, there is increasing evidence all the time that exercise delays disability in Parkinson's disease. So exercise itself has been shown in laboratory animals to increase expression of brain growth factors. It's been shown to slow memory decline in Alzheimer's. It is generally, good for the brain. Good for the brain. Anybody, so if somebody tells you they're worried about developing some, name your neurological illness, the thing you could tell them, exercise. Exercise. What type of exercise for how long is yet to be determined. There's a lot of research on how much and what kind. To date, all of the studies on exercise in Parkinson's disease have been positive. Exercise research historically was kind of hard to do because people lie about how much exercise they do. So when you ask them, they don't do as much. Now we have these gizmos that you wear, and they measure how much you exercise, and so we don't even ask you anymore. We just say, wear this, and unless you put it in the washing machine to make it go around, we can tell how much you're exercising. So I believe in the next couple years, we will be much better at giving exercise prescriptions. Do this kind of exercise for this long, for this much. So for medication, so I said there was no proven medication to slow disease progression. We have many, many symptomatic therapies for Parkinson's disease. So symptomatic therapies are just what I said. They relieve symptoms. They make you feel better. And in general, all of the medications for the motor symptoms of Parkinson's disease revolve around dopamine. I said that you lose those cells that make dopamine. So the treatment for Parkinson's disease are medications that replace dopamine, augment dopamine, imitate dopamine, everything dopamine. So those are generally the current symptomatic medications. Carbidopa, Levodopa is the mainstay therapy for Parkinson's disease. It was approved in the early 70s. It is the answer on the test when they ask you if you have Parkinson's disease and you're on a desert island and you can have one medication, this is the one. It is the single most effective medication. It increases lifespan in patients with Parkinson's disease. In other words, prior to the advent of levodopa, carbidopa, patients with Parkinson's disease died of complications of being immobile. Usually about 12 years into the disease. So it's a real miracle drug. It actually has 2 drugs in it. So the Carbidopa is a single drug. It is in there to prevent the Levodopa from converting to dopamine in your liver. Dopamine can't get into the brain from the bloodstream. Levodopa can. So if we gave oral dopamine, you would get nauseated and none of the Levodopa would make it. If we just gave Levodopa, which was done briefly in medical, if we just gave Levodopa, you would need about 10 times more Levodopa than you currently take. And it would take a long time to build up tolerance to the nausea. So the Carbidopa in there blocks, not 100%, but much of the liver's ability to convert the Levodopa to dopamine in the periphery, lets Levodopa get into the brain, and once it's in the brain, then be converted to dopamine. There are currently many, many different formulations of Levodopa Carbidopa. It's available in traditional tablets. It's available in various controlled release preparations. It's available in a gel that goes in a pump that is pumped directly into the small intestine. In other formulae, there's an inhaled formulation that's under investigation. There is a formulation that might work in a subcutaneous pump that is under investigation. So there are a lot of reformulations of this medication because it is so potent. There are also a number of medications that augment levodopa. Although levodopa is very effective, its duration of response is not very long. And what I mean there is not the fact that, like, if you take it now, 5 years later, it won't work. What I mean is that when you take a dose, that dose wears off pretty quickly. And generally, the duration of response from levodopa shortens as the disease progresses. Your brain loses the ability to store levodopa over time. So in the most kind of advanced cases, levodopa might just last a few minutes. So that's why there are these controlled releases formulations and things that augment levodopa. So there's a class of medications called COMT inhibitors, entacapone and talcapone, which go under the brand name Comtan and Tasmar. There's also a medication called Stalevo that has levodopa, carbidopa, and entacapone all in the same tablet. Entacapone blocks the breakdown of levodopa in the liver by another branch that doesn't form dopamine, but it makes levodopa more available. Monoamine oxidase inhibitors block the breakdown of dopamine in the brain. Once levodopa is converted to dopamine, monoamine oxidase inhibitors allow that dopamine to stay around longer. And so both COMT inhibitors and MAO-B inhibitors increase the duration of response to levodopa. So you take a levodopa tablet, and that levodopa lasts, an hour. You take a levodopa and a COMT inhibitor with it, lasts an hour and a half. So it's made to lengthen the duration of response. Finally, there's a medication called amantadine. It blocks reuptake of dopamine. So when your brain secretes dopamine, it generally likes to secrete stuff and then take it back. So amantadine blocks some of that reuptake, allows levodopa to work longer. It also, in some patients, decreases dyskinesias. Dyskinesias are the involuntary movements that are due to levodopa. and are seen in some patients. Dopamine agonists are artificial dopamine, so they are molecules, medications that stimulate dopamine receptors, act like dopamine. These are medications like Mirapex or Neupro or Requip or Apokyn that are available in various formulations. In general, dopamine agonists don't give the same quality of response as Levodopa, so they're not as potent as Levodopa, but they have a longer duration of action. They're not affected by food like Levodopa, and so they generally have a more smooth response. And they are often used in combination, so it's not unusual for somebody to be on a combination of Levodopa and dopamine agonists. They may be more likely to cause nausea than Levodopa. And so as you can see, there's these various medications, and everybody's different. And the trick is to, through trial and error and trying to match patients' individual problems to medications, come up with an optimal drug regimen. All of the dopamine medications have side effects. They have similar side effects. Nausea is probably the most common. Low blood pressure we talked about. Some of them can cause sleepiness, or what's called sleep attacks, where you fall asleep even though you're not sleepy. They can make nightmares more common if they're taken at bedtime. They can cause hallucinations, particularly in people who have memory difficulty. And they have this rare side effect of what's called impulse control. And these are a fixed behavior that cannot be controlled. And interestingly enough, they've always caused impulse control. Impulse control was not really reported in the literature until gambling became more common in the United States. And with internet gambling and the lottery, impulsive gambling became an issue. People lost large amounts of money because they couldn't stop gambling. Prior to that, people were doing impulsive gardening, impulsive button collecting, and so they were eccentric. Impulsive gambling is a problem, but it can cause that, and it's important that you realize it. There are motor fluctuations. So as the disease progresses, I said the duration of response shortens, so you can't have wearing off, which is the reemergence of motor symptoms between doses. You can also have dyskinesias. These are abnormal involuntary movements that typically occur at the peak of a dose. And in general, because I said your brain loses the ability to store medication, the simplest treatment for motor fluctuations is more frequent, smaller doses of medication. So this is a graph of that. You can see early in the disease, you kind of have this, you're able to store medications and you have this smooth response. As the disease progresses, the response becomes shorter. As the response becomes shorter, and you become more likely to develop dyskinesias. And so that's where pumps and patches and deep brain stimulation come in to kind of smooth the response there for that. Occasionally, people will lose their response to medication. There's a lot of reasons for that. Probably the most common one is inadequate dose. The disease progresses and they don't take enough medicine and they outgrow their dose. There are medication interactions. The most common medication interaction is all of the common medications, all of the common prescription medications to treat nausea block dopamine. So if you get sick and your doctor gives you a prescription for Phenergan or Compazine or Reglan to treat nausea, that will block, dopamine and temporarily make your symptoms worse. In some people, protein interferes with levodopa. We don't really tell people to alter their diet. If they notice it, they can alter their diet, but otherwise they got more things to worry about than that. High doses of vitamin B6 interfere with the way that Carbidopa works and can make your levodopa less effective. Also, if you get sick, so if a Parkinson's patient gets the flu, gets a urinary tract infection, gets depressed, their motor symptoms will generally get worse until that other illness is treated, and then it comes back. So anybody who has an abrupt worsening of symptoms, we always look for what else might be going on. And then finally, you could be misdiagnosed. So particularly early on, if you think you have a response, but then later you don't. Remember the fifth cardinal feature was a response to levodopa. If you completely lose your response, it may have been a misdiagnosis. As far as kind of tips on medication, first thing is that there's no evidence that medication speeds progression of disease, so you shouldn't necessarily be stingy with your medicine. There's no reason to hold it back like a trump card to play later, like I want to be on a low dose now so that when I get worse, I can be on a high dose. There is reasons both to save money and to decrease side effects, not to be on more medication than you need to be. But you need to be medicated well enough that you feel like you can exercise, because exercise is really important. We all get hung up on the numbers. We all get hung up on, well, Joe's taking this much and I'm taking this much. That must mean he's better than me or I'm better than him. There is only a rough correlation between dose and disease severity, okay? Levodopa is so poorly absorbed in general that some patients who have mild symptoms require a high dose because they don't absorb it very well. And some people with bad symptoms require a low dose because they absorb it really well. So if you're comparing levodopa doses, it doesn't have anything to do with disease severity. And then, medications change over time. Your disease changes over time. So there's a lot of tweaking and adjusting that goes on over time. In general, for most medication regimens, the interval is more important than the time. And what do I mean by that? Well, it's more important if your drugs are at 4-hour intervals, that the interval is 4 hours rather than you take it at 6, 10, 2, and 6. So if you get up at 5, you're at 5, 9, whatever, at 4-hour intervals. So it's hard to remember medication multiple times per day. More and more people carry a phone with them all the time. A lot of people are tempted to use the alarm feature in their phone. I would recommend using the timer feature in your phone rather than the alarm. The timer is an interval. The alarm is specific times. And, if you're a little late or you want to be a little early on your medicine, the next one is whatever your next interval is. So I would use the interval timer. In general, more frequent, smaller doses have fewer side effects for a given amount of medication. So if you're having nausea or other side effects, rather than necessarily decreasing the dose, you can split it up into more frequent, smaller doses. And remember that at least for Carbidopa, Levodopa, the effect doesn't really get to your brain for 45 to 60 minutes. So if you think that levodopa makes your symptoms worse because when you take a pill 5 minutes later you're worse, that's because the pill before that one is still wearing off and the one you just took hasn't made it to your brain yet. So remember that there's a delay. Also, if you have a symptom, people often say, well, I got this pain in my leg. Is that due to my Parkinson's disease? Well, if you take a Carbidopa, Levodopa, and that pain goes away, it is probably due to your Parkinson's disease. This is depression in Parkinson's disease. We talked about it before because I forgot I had a slide on it before. This is exactly what I said before. If you have depression, I would encourage you to get it treated because it will make your life better. Melanoma in Parkinson's disease, if you're a package reader, if you're a package insert reader, melanoma is in every single package insert. The evidence that levodopa carbidopa increases your risk of melanoma is pretty slight, pretty slight. There have been various studies about melanoma risk in Parkinson's disease. Some have been slightly positive, others have been completely negative, so it's a little bit like brain tumors in cell phones. We don't know yet, but it turns out that men are more likely to get Parkinson's disease than women. We don't know why. That having a history of living in the country, rural living, increases your risk of Parkinson's disease. And that whites have an increased risk of Parkinson's disease over African Americans. So it also turns out that old white farmers are also more likely to get melanoma than anybody else. So they share a common environmental risk. But we do encourage people, if they had to, look for melanoma and to see their doctor if they have suspicious lesions and get them checked. But it's not a big risk. As far as clinical trials, a lot of times people are interested in clinical trials. The government maintains a website at clinicaltrials.gov that lists all the clinical trials for every disease going on in the United States. There are often strict exclusion criteria for clinical trials, but I would encourage you to participate if you qualify. Kelly Arney has a booth outside from Vanderbilt, and you can sign up with her. She has an email thing that announces all of the clinical trials that are going on locally. You should never, ever, ever, never, ever, ever pay for an experimental therapy. So ethical experimental therapies are not done at patient expense. So, gene therapy for Parkinson's disease, stem cell therapy for Parkinson's disease, that you fly to Germany and pay $50,000 to get a stem cell therapy, is taking your money. Stem cells are under research. There are research protocols for stem cells where you can get stem cells and you're volunteering and do not pay for it, so do not pay for experimental therapy. Also be aware of testimonials. The most common one is the marijuana video on YouTube. Marijuana makes you feel better. That's why it's a great recreational drug. And if your tremor is driven by anxiety, marijuana decreases anxiety. So if you have anxiety driving your tremor and you take marijuana, your tremor will decrease. It will also decrease with a couple of martinis. Your balance will go to heck with marijuana. So there's no evidence whatsoever that marijuana helps Parkinson's disease. What should you ask your doctor? So part of this is training doctors how to treat Parkinson's disease. And you can, this is what you should ask your doctor when you go see him. Or questions your doctor should ask you, and you should be ready to answer. Is your medicine working between doses? Is your medicine causing side effects? Hallucinations, nausea, low blood pressure, sleepiness, impulse control. He or she should ask you if you're depressed, if you're having memory difficulty. Are you falling? Are you sleeping well? Are you acting out your dreams? And the reason they should ask that is that we have treatments for those things. And so those are treatable aspects of Parkinson's disease. Should also ask you if you're exercising, and if you aren't, he or she should yell at you, because You should be exercising. It delays disability in Parkinson's disease. It's going to be on the test. You should be informed. You need to get information about Parkinson's disease, and beware about fake news. Fake news exists in the medical literature also. You need to have a reliable source, and there are several. Davis-Phinney Foundation has a website with reliable sources on Parkinson's disease and what you should do. The National Parkinson's Foundation, the National Institutes of Health, the Michael J. Fox Foundation. All of those have reliable, patient-centric information on them. There are local resources. The tables are outside for Parkinson's lecture series, Parkinson's exercise programs, the Peterson Foundation. You need to get involved locally with Parkinson's disease and move things along. So as far as the action steps for this, you keep learning. Go to Parkinson's Disease 102. You got an excellent list of lectures today. Get involved locally and nationally in Parkinson's disease research, and finally keep moving, exercise. So I think my time is up. You gotta go to your next class.